Yeah, good evening, everyone. Myself, Dr. Meenal Sharma, and today we are going to have a discussion on keys for a successful implants. Here we have Dr. Hemant. He is associate professor in Sri Aurobindo University, Indore. And he has his own practice also, and he as a dental creators, and he specializes in laminates, implants, and other. He keeps on doing other courses also, and he has done multiple international and national publication, and here we are going to have deep insight for the how to the key points for this, how can we proceed for the successful implants, and what are the new techniques and upcomings. In short, we are going to see how it is useful for the practically in the practice, and definitely how AI is going to be helpful for the implants. So over to you, Dr. Hemant, and thank you so much for joining on Muskan.ai, and we welcome you on our platform.
Thank you, Dr. Meenal, for giving this great opportunity to enlighten our clinicians about the implantology. So, myself, Dr. Hemant Gadge, I am Associate Professor in Sri Aurobindo College of Dentistry, Indore, and I am MDS in Prosthodontics. So, today's topic is key to successful implants. So, what are the key to successful implants? How we can succeed in implantology? In this modern era, what we are seeing, everyone is running behind implants. Everyone want to put the implants in oral cavity. Everyone want that we should go for implants, but nobody is learning about what are the effects after placing the implants, or what precaution we should take after placing implant, and what are the causes of the failures. So we are going to discuss about the main key factors which are responsible for our successful of implants. So dental implants have become mainstream with more practitioners doing them. They enjoy high degree of success from 90 to 95% at 10 years. But even with this high degree of success, there are failures too. These days, discussion in dentistry are not about placing more dental implants, but how to deal with the complications that arise when dental implant begins to fail. So what we are going to discuss here, like that we are placing implants, but when implant fails, we just set us down. What now we have to do? So how I have to deal with this types of the failures. So when considering dental implant treatment for a patient, a clinician must evaluate whether implants are the best option to restore the patient's function and aesthetic. We should assess the risks, medical history, medication history, lab evaluation, dental history, clinical exam, x-rays, and soft and hard tissues before placing any implant. These are the must things which we have to assess before placing any implant. It's not like that there is bone we can directly go and place implant. We have to assess all these factors, because all these factors combinedly go for successful implant only. So what we have seen in introduction, there is 90% to 95% success rate in implant placement, but there are failures too. So the 5 to 10% of dental implants which fails are caused by mainly three reasons. First is periodontal problem, or what where we say peri-implantitis, or the inflammation around the dental implants. Second is lack of adequate osseointegration, means the fusion of the bone to the implants. It may due to poor bone or the soft tissue support around the implant. And third and last, after placing implant, we are going to load the implant with prosthesis. So the inadequate force passing through the implant may cause to the fracture of the dental implant or the abutment. So these are the main three causes which lead to the failure of dental implants. So when considering about dental implants, it is a team effort between dentist and the patients, because both have to support each other. Because if we are placing the implant in patient oral cavity, but patient is not taking only any oral hygiene, the implant will definitely fail. And it's vice versa. If patient has good oral hygiene and he is taking every care, but we are not placed the implant properly, we are not maintain the bone structure, we are not for the bone structure, we are not managed the soft tissue support, then also the implant is going to fail. So each has a role in the overall long-term success of the dental implant treatment. So for successful dental implants, there are 7 key factors to be considered for success of a dental implants. So we are going to learn about 7 key factors for success of dental implants. So the key number 1, or the first key for success of implant, is the assessing the medications. First of all, we should know the medical history of a patient. As much as 48% of the population takes at least one medications. The 31% takes at least two medications, and 30% takes at least five medications. The 30% of the elderly population takes at least 8 medications per day. Knowing what medication your patient takes influence the surgical healing of the soft tissue and the bone around dental implants. So first key is about medications. We have to assess the medicines what our patients are taking. So in short, what I am telling that we have to assess the medical history of the patient. Sometimes we ask patients, do you have any medical condition? They deny it at once. No, सब कुछ ठीक है हमारा, कोई problem नहीं है. Then we ask, sometimes I ask, what I do in clinic? I ask patient, कोई दवाई ले रहे हो? हाँ डॉक्टर साहब, सुबह दवाई लेते हैं खून पतला करने की, बस भाई कोई तकलीफ नहीं. So what is this खून पतला? Means he is using some type of aspirin or ecoaspirin he might be taking, or she might be taking. So we have to know about the medicine which the patient is taking. By this we can know about his medical conditions. So first assess the medical condition of the patient, then only go for other options. Okay. For example, if patient is diabetic, he or she will be having delayed healing, and he or she is more prone to infections. So we have to divide our medications also according to the patient to patient. Okay. We might need a combination of drugs in these diabetic patients. We may go with Amox CV plus Metrogyl also, because we have to keep our surgical site clean or free from the infection. So first assess the medication, and there is no absolute contraindication except bisphosphonates. The bisphosphonates is the absolute contraindicated for implant placement. What happens in bisphosphonates? Because by taking bisphosphonates, there is loss of blood supply to the bones, due to which when we place implant, so while placing implant, the heat is generated. Now you might be thinking we are continuously irrigating, but irrigation fails in these cases because it is going to produce some amount of heat, and the supply of blood is less in this type of cases. So it may lead to the osteonecrosis or the fracture of the bone. So the bisphosphonates are the absolute contraindication for the placement of implant. Otherwise, in all cases, we can go for implants. And such or another disease such as autoimmune disorders, they are also contraindicated for implants. The second key factor is good oral hygiene. So in photograph, you may be seeing the huge amount of calculus is accumulated in lower anterior region. So what will happen? We put implant in this type of patient. He or she is having a tooth. He cannot preserve that tooth. So how we can accept or expect from that patient that he or she will keep the surgical site clean? So first we have to orient the patient about the implant and the oral hygiene habits. If patient is going to keep clean oral hygiene, can maintain surgical site clean, then only go for implant. Don't go for implant in such type of patient, because in the end the implant will fail. Then he will ask, मैं वो सब कुछ ठीक रखा था, आपने गलत किया है. Okay? So the plaque and bacteria which causes periodontal disease can cause periodontal disease around dental implants, also known as peri-implantitis. The failure to develop a sound oral hygiene regime with your patient with a regular maintenance schedule is paramount for long-term success. If the patient cannot keep their mouth clean, then they are not good implant candidates. So the key is the patient should able to clean his oral cavity or keep his mouth clean after surgical procedure. Okay. We can prescribe to patients some oral rinses, mainly chlorhexidine mouthwashes. That too after 3 days of the implant surgery. Now, the third key is the bone and the soft tissue available. In this diagram, you might be seeing the first photograph is about CBCT of a patient. What we see in this patient, the labial plate is almost very thin, or we can say not available there only. Okay. So first you should assess the bone quality and quantity and around surrounding soft tissue, then only plan for implant. Just like building a house, you need a proper foundation to support the house. The same is true for dental implants. You need adequate bone for proper placement and positioning of the dental implants. You also need adequate soft tissues to protect not only the dental implant but also the underlying bone. If you start to lose bone around the implant will fail. The proper support and placement of the dental implant will make it easier to clean and withstand the forces of your bite. In situations of inadequate bones or soft tissue, there are a number of minimally invasive procedures that can perform to rebuild the bone or soft tissue. So first we'll discuss about this case. In this first CBT, we can see the bone quality is very poor. The labial plate is very thin. So when we are going to drill or we are going to make ostomy, this plate will definitely break. So what we can do in this case? First, we can go for bone graft. We can place bone graft and just leave it for 3 to 4 months for the formation of bone. Okay. Second option, what we can go for is we can go for block graft. We can take a graft from a mandible site, and we can put graft over this labial plate and on incisal part or the occlusal part. We can screw it and leave it for 3 months, and after that we can go for implants. Second, for soft tissues, if there is any inflammation, we can just open the flap, curate it, and just suture it for 21 days. Then we can go for implants. So the individual element of CBCT image is called as voxel, and which demonstrate the density of the bone at that point. So what we are seeing, the amount of the bone or density of the bone by CBCT images. So the bone is classified into 4 types: D1, D2, D3, and D4. The D4 is the worst type of bone. Okay, and D1 is the strongest bone. But the very good and the perfect bone for implant placement is D2 type of bone, because D1, the cortical bone is very thick and the amount of blood supply is less in D1. But in D2, the thickness of the cortical bone is uniform and it has a good amount of blood supply. So the D2 is the very perfect bone or very good bone for the placement of the implants. So how we can know these values, or how can we know about that this bone is D1, D2, D3 or D4? So for it, we have to remember these values. D1 1250, D2 850, D3 350 to 850, and D4 150 to 350. If you can't remember, just paste this chart where you keep your laptop. So how to check this density in CBCT? So first, open a CBCT. Okay, adjust your angle or the site where where you are going to place the implant. Okay, then open the cross sectional area of that part where you are going to place the implant. When you will click once, then some type of the units will pop up. It may be 2000, it may be 800. The 2800 or any value which are popping up, they are showing the density of the bone. So just note down the density and see in which group it is coming, D1, D2, D3 or D4. And in this way you can know the density of the bone at the site where we are going to place the implant. So now the key number 4 for placing the implant is the planning of the case with the tooth position. The tooth needs to be in a specific position in order to withstand the forces of the bite, as well as maintain the aesthetic of the final restorations. So the proper positioning of the dental implants makes oral hygiene much more predictable. The position of the tooth needs to be dictate the surgery. Any insufficiencies in either the bone of soft tissues must be addressed prior to the implant surgery for a predictable long-term outcome. So what does the key number 4 means? Simply it says that we have to plan the case. Okay. Just we have not to place the implant. We have to plan the case in such a way that after placing implant, when we are going on the prosthetic phase, what will the position of the that processes or the tooth in the final processes? If you are giving very too much angulation in anterior region, so what will happen that the teeth will be more labily placed. So you have to adjust the angle of the implant in such a way that the final position of tooth should be in aesthetic zone. Okay, if you are going for posterior implants, it should not be more buccally placed or not so much lingually placed. Slight angulation is okay, but you should not place more buccally or more lingually. Generally, in mandibular arch, we place implants slightly tilted lingually. Okay, and in case of maxillary arch, we place implant slightly tilted buccally. Means the head of the implant should be buccal while the apex of the implant should be palatal. And for in mandible, the apex of the implant should be towards buccal side and the head of the implant should be slightly lingual. You might be thinking why we have to tilt the implant slightly. There is a simple reason. We have studied in our second year BDS only in preclinical prostho, or you might be have also learned in our final year BDS in prostho. When we arrange teeth in edentulous patient in mandible arch, the mandibular teeth, which are posterior teeth, are slightly inclined lingually. Okay, because the center point or the central fossa should lie exactly on the center of the ridge of the mandible. So this basic thing is also followed in our implant practice, because the forces should come should direct it directly on the center of the ridge, which will cause our long lasting of the implant. If it is not balanced, then only the failure of the processes or the fracture of the crown or the fracture of abutment or screw takes place. Otherwise, the implant might fracture from the neck. So just follow the rule of the occlusion rules, which we have learned in basics in second year or final year. Now the key number 5 is we have to choose the right width and length of dental implants. Okay. Generally, we have to go with narrow implants for anterior teeth and wide implant for the posterior teeth. Okay. It's not like that we have to go 5 mm or 6 mm width implant in posterior. We have 12 mm of width of implant. No, 4.5 or 5 mm amount of width is sufficient for a dental implant to take the load of the processes. For anterior, 3.5 or 3.75 millimeters enough for anterior ones. It's not like there is huge amount of bone present, so we can go for very wide implants. The ideal implant for anterior tooth is 3.5 millimeter. For premolars, it is 4 to 4.5 millimeter. For posteriors, we can go for 4.5 to 5 millimeter of diameter. Okay. As the diameter increases, the length of the implant should decrease. What I am telling, we have to give the length more in anteriors and width should be less, while in posterior part, the length should be less and width should be more. Because in posterior, the surface area of tooth is more, so we need wider implants. So while dental implant companies make all varieties of width and lengths of dental implants, choosing the right size dental implant is key and instrumental to long-term success. It should go without saying that big teeth or the posterior tooth need wider implants, while the smaller teeth or the anterior teeth needs narrow ones. Too often, the surgeons allow the bone to dictate the size of the dental implants rather than making the bone fit the proper size implants. So the last line, what it says, the surgeon allows the bone to dictate the size of dental implants. This is the very critical point. It's not like that we have very huge amount of bone, 10 mm or 12 mm. Then you can go for 6 mm implant. Just stick to the basic. Go for 5 millimeter of implant. Okay, and you can go for 8 millimeter of length or 7 millimeter of length is enough for posterior ones, 6 and 7. And for anterior, you may go for 13 till 13.5 millimeter and 3.5 millimeter of diameter. This will be enough for the any process to withstand for a long time. Now, key number 6, taking advantages of new technology. Now, here comes the technology used in implantology. Different technology has been there. First is uses of CBCT. Okay, just go for CBCT when there are multiple implants, 2 or more implants. Okay, and when you cannot go, when you are not going for immediate implants, immediate extraction implants, then just go for CBCT for clear review. Second one are surgical guides. The surgical guides are more accurate because they use CBCT data to know about the path of implant placement and the amount of bone placed. And third one are the implant navigation system. This implant navigation system is totally AI based implant system. Okay, so we are going to learn about uses of CBCT, surgical important surgical guides, and the newly introduced implant navigation system, which is totally AI based. So you this is the photo of a CBCT image of a patient. The first view is about the OPG view, which is two-dimensional in nature. In this, what we can see generally, the 2 dimensions or the bone. So when we see closely, what we see anterior region is the sockets of lateral, central, and lateral. Okay, but we cannot see the width present over there. But in CBC, what we are seeing in cross-sectional view, what we are seeing that there is no labial plate present at all, which cannot be viewed in two-dimensional photograph or two-dimensional view. So this gives us a very clear view about the bone morphology and the amount of bone present or what type of bone it may present over there. So just go for CBCT for precise implant placements. Now, what are the advantages of CBCT? First is the identification of the diseases. Okay. Second is the amount of bone quality and quantity we can know about CBCT. We can determine the position of implant in CBCT and determine the implant orientation. Okay. We have learned about the bone quality and quantity. So, how we can know about the implant position and orientation of the implant in CBCT. Okay. Most of you might be using CBCT. So, in that, when we measure length and width of the implant, in that left side we have a one small logo of implant. Okay, when we click on that implant logo and measure the length of the implant and width of the implant, then a library pops up about the implant. In that we can choose the diameter and length of that implant. So just to choose the diameter and width and the length of that implant and click on it. Oh, click on it. Then the next window will pop up of OK. Just click on OK. Then immediately the implant image will appear on the side where you are going to place implant. Okay. There you can adjust the angle of the implant. After adjusting the angle of the implant, go for three-dimensional view of the maxillary or mandibular site where you are going to place implant. In that, you can know about the implant orientation. It is going in arch or away from arch, or it's touching any vital structures or not. So this in this type you can know about the orientation of position of the implants. So what are D1, D2, D3 and D4 type of the bone generally in which we can place implant? In D5 we cannot place any type of implant because this is immature and non-mineralized bone. In D1 it is a dense cortical bone. D2 has thick, dense to porous cortical bone on crust and coarse trabecular bone within. D3 has a thin porous cortical bone on crust and fine trabecular bone within, while D4 has the fine trabecular bone. And one more thing, we can convert the bone density from D4 to D2. What I want to say that if we have got a patient in which he wants to get implants done, but the bone quality is very poor. It might be D4 type of bone. But in D4 type of bone, matlab means ki D4 type of bone is very, very soft, due to which we will not get the primary distributed implant. But we can convert that D4 type of bone into D3 or D2. So how we can convert that D4 into D3 or D2? Just we can go for bone grafts. We can put bone graft in that part, which will condense, and after osteogenesis it will form a very good type of bone. In this way we can convert the bone, or we can harvest the bone from other sites also. Now the second is the surgical guides. So what are the surgical guides? The surgical guides are just like a stent, or what we can say, it gives the position of the implant and the orientation of the implant. Okay. So the surgical guides may be of two type. It may be fully guided or partially guided. Partially guided means just they are used in the first drill, means we get just the angle of the implant. in which direction we have to make the osteotomy. But the fully surgical guides are in which we can just place the implant in the position and orientation. The fully surgical guided guides. So how they are made? You should have a good lab about this. Okay. So what will lab do? We have to send the CBCT to the lab. So after sending CBCT, the lab person will analyze the data. After analyzing data, he will check the sites where we can place the implant. Okay. Or we can ask the lab person which are making the fully guided surgical guides that we are going to take these types of or this length of implant this region. So what he will do, he will just make a guide in which when you are going to drill, for example, we are going to drill in canine region. Okay, so he will make the diameter about the implant of around 3.5 millimeter, and length might be 11.5. So we will go for 11.5 only. So when you are going to drill, your burrs or the drills will stop at 11.5 only. Okay, you will not go beyond 11.5 because surgical guide has a stoppers and they will stop you from going more deep. Second one point, what we are important, that the width of the implant. In this, if you are going from 2.2 to 3 mm or 3.5 mm, whatever diameter the lab has given, for example, if he has given 3.5 mm diameter, the final drill which will be passing through this one will be 3.5 millimeter only, not the bigger drills. Okay, so the fully guided surgical guides are very handy and useful, especially for full mouth cases. And there are surgical kits, the general surgical kits which we are using in clinics are different from fully guided kits, because in diagram you might be seeing there is a hole and you can see the metal sleeves in anterior regions. So there is some width and length of the sleeve also. So the surgical guides will be having this metal sleeves with certain amount of length and the width. And the surgical kit which we will using for this implant placement, fully guided implant placement, they are termed as the fully guided surgical kits. Okay, this kit will be used for placing the implant only, not our regular kits. Now moving to the newer advanced technology. This is the implant navigation system. Picture is not very clear, but what we can see in this is implant navigation system. You all might be doing endo work. Okay, so what you do in endo after SS opening, you just use your apex locator. It just beeps and gives you the apex that we have used the apex. Okay, so in implant navigation system, what is done, we have a complete system of a system on PC or laptop. In this, the handpiece is connected to a CBCT app. Just first we have to load a CBCT. It's loaded in the PC. It is connected with the software, navigation system software. And when you are going to drill in oral cavity, okay, you will be seeing two types of light or two types of color. It may be green or red. Green means you are going inside the bone and you are in center of the bone or center of the ridge. Okay. As you are going to drill further inside, then you may be seeing in front of your screen also, you are going inside. As you will reach near to the nerve or any vital structure, it will just beep up. You will stop over there. And if it shows red, means you are just near to the vital structure. So this is the most advanced navigation system which is available here. In India, we also have the navigation system. You might be knowing about Dioneo. This is the implant name system which is in India right now. Now, the last key factor for implants is the knowledge of good surgical and suturing technique. So, we have followed all the protocol from 1 to 6, but you have not done good surgery and suturing technique, the implant will again going to be failed or have infection. So, whether placing dental implants or performing bone grafts, these procedures must be done as well as. And it is vital that they be covered by the soft tissues. There are specific situations in which implants do not need to be covered by soft tissues, but bone graft needs to be covered. So the knowledge of the good suturing technique to hold the gum tissue in place so that the bone graft or the implant are protected from the oral environment. And it is vital for the long-term success of the implants. If the gum tissue opens, then the bone graft or the implant become exposed to the oral environment, and which then put the graft or implant at the risk factors. Okay. So after the placing implant, we have to suture them very tightly or good, so that they should not open within 7 days. If they will open, the soft tissue will open up and the patient might get inflammation over there. Okay. And if we are going to place graft, so we must place GTI membrane over graft every time, because graft may be displaced while placing the suture. So GTR membrane is must, and we should place GTR membrane after placing the graft. Okay. And sometimes we do not put cover screws. In what cases? When we are doing punch technique, means we are not opening the flap, we are doing punch and placing the implant, then only we don't put sutures or cover the soft tissue. We directly put gingival former or the gingival abutment over there. The gingival abutment or gingival former will cover all the soft tissue, and no food debris will go inside it. But patient has to follow the oral hygiene instructions. So what is the conclusion of this our topic? The commonly accepted criteria for the assessment of implant success were proposed to identify clinical evidence of successful osseointegration and survival of implants. And over the past 3 decades, the implant success has been assessed by survival rates, not by placing the only implant, but by the survival rates, continuous prosthesis stability, radiographic bone loss, and the absence of infection in the peri-implant soft tissues. So, what the success of implant means how long your prosthesis over the implant, how much bone loss is there after placing the implant, after loading the implant, and for how long time the site was infection free. So this was a short lecture about my success to implants. There are many factors, but these are 7 key factors, and these are general 7 key factors which we can incorporate in our day-to-day daily practice. Okay, thank you.
So, thank you so much, Dr. Hemant. It was informative information you have shared with everyone. And implants or dental implants plays very important and very vital role in dentistry. There are various types of implant, and here the key success, the 7 key features are will play definitely important role from start to diagnosis planning till in the end when we give the processes. So I would request everyone, if they would like to, they have any questions, so they can raise their hands, and we can have a session, have interaction with everyone. So we can take questions now. Anyone, any questions? So, Dr. Hemant, can you share some insights for the types of grafts when there is a like labial bone is not at the whatever is the length we wanted? Yeah.
Okay.
So, Dr. Vishal will take your question also.
So, what you asking me about the labial bone? Okay.
Yes.
So,
Yeah.
in my paper, there was a simplicity in which I have shown that the labial bone was very thin or not present at all. If the labial bone is very thin, okay, we just we just can drill, or we just can go some palatally or lingually,
Hmm.
and we can go for our pilot drill
Yes.
after making
Yeah.
after
No.
pilot.
The type of graft which you would suggest for the labial cortical bone, or if it is not present or if it is less.
Yeah, ideal bone will be, we can go for block graft only.
Okay.
Yeah, this is the ideal bone graft. Ideal
Okay.
one. We can take a graft block from the mandible, maybe from symphysis area, parasymphysis area, and just we can put the graft over labial plate and then screw it and put the suture over it. And after putting suture, we have to put our CO pack over it and just leave it for 3 months. But we have to
Okay.
do follow up every 7 days, 21 days, because we have to change that pack, CO pack.
Copac.
Yeah,
It's an autogenous graft, basically.
yeah, yeah, yeah.
Okay. So we would like to know if now the artificial intelligence it is coming in all areas of the healthcare in routine life also. So how
Okay.
AI will be very helpful for the
Mhm.
specifically for the prostho specialty
Yeah,
or the
yeah. This question is from Dr. Vishal. How AI is useful in implants?
yeah.
So, Dr. Vishal, AI is what? It is artificial intelligence. Okay. What we are using day to day in our dentistry nowadays all comes with artificial intelligence. The endometer which you are using, okay, which is also a type of artificial intelligence. And for implants, the what you are asking me is about implants. So for implants, first is CBCT. Okay. See, after CBCT, what we have done, we can go for surgical guides, fully guided surgical guides. Okay. The fully guided surgical guides are made by the help of CBCT only. Okay. Then the surgical kit which we are using for placement or implant are total different. They are fully guided surgical kits. Okay. This one is the one used for implants. Second one is more important, is what I have included in this is implant navigation system. You can see your placing the drill, where you have been in the bone, all you can see on the screen now. So after opening a flap, or you are going with the punch technique, when you are drilling the first drill, marking drill or pilot drill, so as you are going to dig inside or drilling inside, the hole you can visualize on your screen. How much length you have gone, it will all be shown on the screen. So this is very much important or very much good thing which is coming, which is helping in our AI implant systems.
Okay. Thank you, Dr. Hemant. And another question we have here regarding the immediate implants. So, what are the criteria shall we follow for the immediate
So
implants?
yeah, yeah, I have got a question of Raghavi about immediate implant placements after extraction. Yeah, they are good for immediate implant placement, but there should be no periapical pathology presents. Okay.
Hmm.
when we are going for when we are going for extractions, generally we are going for extractions when the tooth is grossly decayed, okay, or there is mobility, hmm, or there is some pathology. If there is slight pathology, first we can curate it and go for implant. But if there is granuloma or very huge pathology, just avoid going for immediate implant placement. Okay. If patient is having trauma or there is bone loss or is having mobile tooth, then we can go for immediate implant placement. And if there is torque is good, 35 to 45 Newton torque is good, and it's anti-lesion, then we can immediate load also that part. And second question is about idea for basin implants. So basin implants, I don't practice basin implants. I am practicing implants in 13 years, but I have not put any basin implants in my single patients.
Yeah, corticobasal implants are quite in the practice,
Yeah, they
and
are
there are
trending right now. But when we see or read the history of the implants, the
mm,
first implant was basal implant, then cortical implant, then subperiosteal implants, then root form implant, and that what we are using are the endosteal implants, and that are the recent implants. Okay,
absolutely.
so we are going again for basal implants. So I don't prefer basal implants.
Yeah. Right. Okay. So here I would, and thank you so much for everyone's time. Any other questions or any other, because implants is vast and there are a lot of research, development, and it is going on. So definitely, Dr. Hemant, you can share your email ID so that everyone can, they can connect you. And definitely we have anybody if they would like to have any questions or something like that, so info@, muskan.ai, they can have their questions, or muskan.ai is open for any new upcoming mm, if anybody would like to share their knowledge for on the online platform, or they would like to do anything with AI, which is research and development. So we are open to give any platforms so that each specialty will have innovation by AI, and that is why we thought everyone should share their ideas, particularly when we speak about the implants or and the rehabilitation. So rehabilitation can be planned in much better way if we inculcate AI in the practice, and gradually we can train our digital assistant like artificial intelligence and machine learning, so that it is will be useful for the ultimately for the clinical practice and for the better outcome. So thank you so much, everyone. And any questions, so I can take it. Okay. Thank you so much, everyone. And I hope this lecture is useful for everyone and in the practice. Still, anybody has any questions, and this webinar is recorded, so we have your own YouTube channel, Instagram page, and all the updates will be there on the YouTube channel. So thank you so much. Yes, definitely. We'll share. We have on 28th of October, we have oral cancer screening by AI. That is Dr. Hitesh Sangvi is going to be there. So stay tuned, and you can approach us for any innovations or anything like that. If you would like to go further, start from the screening to the to the diagnosis or anything like that. So your suggestions are most welcome. We have our LinkedIn page also. And Dr. Hemant, thank you so much for your time, and it was very useful lecture. And definitely in future, we'll have more insights for any specific topic on the implants and the prostheses, and especially
Yeah,
for the
sure.
laminates.
Yeah, thank you very much. Because
Yeah,
yes, yeah, implant subject is very much vast. What
yeah.
I have discussed only simple way what we have to see first of all while doing the patient, because the graft itself is a very huge part. We have
Yes,
to use
yes, yes,
allograft,
absolutely.
allograft,
Yes, yes.
autogenesis
Being a
graft. These are the
maxillofacial
difficult
surgeon,
part.
I can understand. Yeah, being a
Yeah,
maxillofacial surgeon and the
Yeah,
and
yeah.
doing a lot of research in multiple ways. So it is
Hmm.
implants are very vast and grafts and
Very vast.
everything.
Graph.
Yes. So
Nowadays we are doing PSI. That is very vast only. And this is
yeah,
PSI. What is this PSI? It is also by AI only.
yes.
Yeah.
So we are doing a lot of things in the day-to-day life. We are using new techniques the iPhone is there, the Siri is there, the
Hmm.
Alexa was earlier, it was not there. Karma came. So this
Yes.
technology we use it in day-to-day life. The navigation, the most important thing what we are doing it. If you want to go to somewhere, just Google it. And Google is we are training Google basically by giving them data, and that is why the
Hmm.
accuracy is coming after so many years. So it is not about why we should not use it, but if we can reduce efforts and put more efforts in the on the patient, then why not? So we all should join our hands together so that we can reach at such a level that, because right now in the month of September, the owner of the Meta in the Facebook, so he is planning to have AI for the uh, on the cellular level, such chronic diseases where we can put this machine learning in such a way that lot many people can be saved, or they we can change a life. So this is just a start, and coming time within downplanned 5 years, the scenario is going to change completely. Let it be Australian Dental Council, let it be any upcoming or the other countries, they are working on AI and innovations, because day to day there is a lot of updates are there. So thank you so much everyone, and I'll not take much time. So thank you so much. Thank you so much, Dr. Hemant. It was
Thank
great
you.
time, and thank you so much for such a amazing lecture. Thank you everyone. Have a good day. Take care.